Thanks for joining me for this lecture that corresponds to Chapter 9 in your textbook, and we'll be discussing audiologic rehabilitation for children. And I want to be clear at the beginning of this presentation that many times for children we should replace the word rehabilitation and use the word habilitation. If you might recall from earlier lectures, rehabilitation occurs when we're trying to restore something that someone already had. So this would be someone who lost hearing as an older child or an adult. But in many cases, kids are born with hearing loss, and in that case, we're trying to habilitate, so help them to grow and develop speech and language and communication through habilitation. So in this lecture and in this module, we want to talk about infants and preschoolers and then school-age children. And I differentiate because the services for these two groups are very different. So let's think about first, who are we serving here? So we're going to focus a little bit more on infants here at the beginning, and about 1 to 4% of children are born with permanent hearing loss, so permanent would be sensory neural, that's greater than 20 dB HL. HL is hearing level bilaterally, so in both ears. And when children are born with hearing loss and it's very mild, they may just need hearing aids and they'll do very well. But with the more severe hearing losses, they're going to need hearing aids, hearing assistance technology, and also services. So the greater the degree of hearing loss, the greater the number of services that children are going to require. And these services really need to be longitudinal in nature. So they need to have services from birth all the way up to preschool and school age. And the great thing about kids with hearing loss is we are collecting some data longitudinally on how they're performing to look at the outcomes following this early intervention that occurs over time. The first example is in the OCHL study, which stands for the Outcomes of Children with Hearing Loss. It is a multi-site longitudinal study that's funded by the National Institute on Deafness and Other Communication Disorders. One of the major sites is Boys Town National Research Hospital, where I have some friends in audiology. But other sites are University of Iowa and University of North Carolina at Chapel Hill. So 3 awesome places for kids with hearing loss. And they have 317 children enrolled in the study, along with a comparison group of 117 children with normal hearing. And this information is expanded in your chapter, so I certainly want you to take a look at that. So 38% of the children had slight or mild hearing loss, 40% had moderate, and 22% had moderately severe or severe hearing losses. So it had really comprehensive measures, including audiology, speech language, psychosocial. So they really wanted to take an in-depth look at these kids. And what they found was 3 main findings here. The first one, that aided audibility is critical. So not just slapping the hearing aids on, but making sure that the hearing aids are set appropriately. So audibility, they can hear with their hearing aids or cochlear implants in some cases. That the duration and consistency of hearing aid use is also critical. So the kids need to be using their hearing aids. That seems pretty common sense to me. And the third major finding is that characteristics of the language environment impacted outcomes. So if the caregiver was interacting with the child really often, they actually did a whole lot better than caregivers who did not interact with the child as often. So that really supports the fact that as audiologists and speech language pathologists or even educators, we have to get the parents involved because they're the ones talking to the child all the time. So we need to provide parent training on how to emphasize language development in the home. In the second example of a longitudinal study, this was a study at NAL, which is the National Acoustics Laboratory. It's in Australia, an awesome place as well. So this study included children with hearing aids and cochlear implants, and also children with other disabilities. And remember, that number's pretty high, so this is a great group to include. Um, 317 children had hearing aids, and 134 had cochlear implants. Even further information is that 52 of them had bilateral implants, and 19% of the kids had mild hearing loss, 33% moderate, 18% severe, and 107 had additional disabilities. Oops, I forgot the 32% were profound, and then the 107 had additional disabilities. So, what were the main findings in this study? Well, once again, earlier identification equals earlier intervention, which was critical. Earlier diagnosis was associated with higher levels of maternal education and socioeconomic status, and these kids also ended up having better outcomes. Children with more severe hearing loss had earlier auditory and educational intervention. Um, Age at cochlear implant was also important. Additional disabilities were associated with decreased outcomes, which is kind of a bummer, but not surprising. And when they looked at the children's expressive and receptive language and speech production and social and auditory functional abilities, they were at or one standard deviation below the normative mean. So even though we're getting these kids early, they're still struggling. So we must get early intervention. These are kids that had it and they're still behind. So we need to keep working toward improving performance in this population. So continuing to think about the profile of our client. So we really have the early infants there with congenital hearing loss, and they will need to be enrolled in parent-infant programs. And as we talked about in an earlier lecture, through these programs we will develop an individualized family service plan to help focus on what the parents can do at home and what the early interventionist will do with the children. Then we have a prelingual group, which means they lose their hearing before language starts to develop. And many people define this as age 5 because most of your speech and language develops early. Of course, we're still developing vocabulary for many years to come. Sometimes I still learn new words, of course. And so those are prelingually deafened children, and they are enrolled in preschool programs, and by the age of 3 you transfer over to an IEP, an individualized education plan. And then we have children who lose hearing after the age of 5, and we call them postlingual. Adults who lose their hearing are also called postlingual, and they're enrolled in school programs and also have an IEP. So when we look at ages again, the IFSP, the early, is 0 to 3. And then we've got preschool, that shouldn't say 5 to 5, it should say 3 to 5. And then school aged is 5 to 18, or some children who have multiple disabilities that are very severe will stay in the public school system till age 21. So let's think about other disabilities. And as I've mentioned, many kids have other disabilities. And in Texas, that's up to 40% of kids. And in other states, it's also equally high. So, what are some of these other disabling conditions? Well, one may include visual impairments, motor disabilities, intellectual disabilities. They may also be diagnosed with ADHD, autism spectrum disorder, of course, language disorders in many cases. So, a lot of these kids are dealing with many things. So when we think about the settings in which the children will receive these services, we move from kind of more of parent-infant program with a early interventionist to a preschool program to more formal schooling. And the program in which you're enrolled depends on the age, but it may also depend on the severity of the hearing loss and the presence of other disabilities. So most family-centered programs look similar regardless of severity of hearing loss and other disabilities. But the preschool and the school age programs will differ in the amount of how much the child is self-contained in programs. But the main goal, as you'll remember from an IEP, is the least restrictive environment. So we want them to be with their typical peers, but sometimes they need a more self-contained program when they have very severe disabilities or very severe speech language delays or impairments. When we think about the identification process with children, we want to, of course, begin with early identification. So, to identify babies with hearing loss, we do uh, one of two tests, or sometimes both. Some hospitals select to do the auditory brainstem response screening, and some pick otoacoustic emission screening. Both have their pros and cons. The best program will do ABR, and if the baby fails, we'll follow up with an OAE to see if they can pass that. And if they don't pass both of them before they are released from the hospital, then they are scheduled for a more diagnostic test with an audiologist. Unfortunately, our screenings may still miss those with mild hearing loss. Of course, those newborn screenings are going to miss anybody who has a later onset of hearing loss or those who have auditory neuropathy, which is where there's something wrong with the auditory nerve and it's not transmitting information to the brain reliably. And so in those cases, we may catch it with ABR, but we would not catch it with OAE because the cochlea is normal. So OAEs measure a cochlear response, and so they actually are present most of the time in auditory neuropathy. But the ABR, since it tests the actual nerve, would be absent. So we really need to be aware of the different risk factors that are associated with hearing loss. And there are actually quite a few risk factors, including low birth weight, hyperbilirubinemia, which is jaundice, particularly when you need light therapy or transfusions. We also have caregiver concerns, family history, being in the neonatal intensive care unit for more than 5 days, particularly if they have to use ototoxic medications, any in utero infections such as rubella or cytomegalovirus, anomalies of the head or face because the ears actually develop as along with the face in utero. Other ones are syndromes, neurodegenerative disorders, finally got that out, and postnatal infections such as meningitis or head trauma or chemotherapy. So there are a lot of risk factors that are associated with hearing loss. So after newborn screenings, and if a child passes, unless there's major parent concern, a lot of times children don't receive a hearing screening up until preschool or kindergarten. Sometimes pediatricians will do a screening, which is the best approach, but it's hard to do it in really young kids. So really they do it when kids can start to participate around age 3. And when you go to school, any typical kid should receive a hearing screening in kindergarten and then several grades beyond. But if you're going to preschool because you have hearing loss or you have other disabilities, you're going to get it in preschool as well. And kids with hearing loss need a new full audiologic evaluation every 3 years for the school, but once a year or once every 6 months would be ideal when you're being managed by a personal audiologist. So in terms of assessing from a medical and audiological standpoint, of course we need a full audiological eval. We also want to refer parents for a genetic evaluation, clearance for wearing hearing aids, and to get any medical treatment necessary. Maybe they have otitis media or some other ear problem that needs to be looked at by an ear, nose, and throat doctor. So as I mentioned, the evals need for 0 to 3 years. We really do quite a few audiologic evals every 3 to 6 months. Preschool every 6 months. After that, at least once a year would be ideal for kids. And like I said, though, schools only require a new audiological eval every 3 years if that child is coded with an auditory impairment code for the school, an eligibility code for special ed. Let's think about early intervention. So we've talked about the assessment process. Now it's time for intervention. So for young kids, this is our parent-infant program or early intervention program, including the parents, where we develop our individualized family service plan. So during this development of the plan, we want to consider the child's communication and developmental status, the overall parent or family and child participation variables, related personal factors, as well as environmental coordination. There are a lot of different aspects within each one, and I want to invite you to read more about it in your chapter. We also want it to be family centered and home based. So, when we're developing this plan, there needs to be goals that help to support the caregivers and help them understand how to help their infant learn speech and language in a natural environment. We want it to be very relationship focused to facilitate auditory and language development. The ECI provider should be an information resource, a coach, and a joint discoverer. So, this is really a group effort. They also need to be a news commentator and show the parent how to, give news about everything going on in the environment. Oh, did you hear the doorbell? Did you hear the phone ring? They also need to be a partner in play and a joint reflector and planner to help the parent know how to build on what they're learning. So here's an interesting rubric I found for a home visit. So we want to reconnect and review what we did last time when they come in. We want to address the priorities for this particular session with the ECI provider coming into the home. We want to show the parent how to do the activity. Maybe we're going to work on bubbles and the B sound and trying to get the baby to say buh, buh, buh. So show how to do the activity, assess and evaluate how the activity went. At the very end, we want to reflect on the home visit. So how did this go and how can the parent carry on with this activity throughout the week or expand on it in other activities that the child does in everyday life, like the bath time routine, the changing the diaper, the playing with toys. So what else could the parent do to continue to work with on the B sound with the child? What are some specific areas that we need to coach and guide parents? Well, number one, obviously the hearing aid. We need to help them understand the importance of audibility and using the hearing aid consistently. To do that, we need to give them a thorough, well, first of all, we need to do a good fitting, but second of all, we need to provide a good orientation. So over on the right, this figure tells you about what they might need to know. Turning the hearing aid on and off, identifying the left versus the right hearing aid, changing the batteries, how to put the hearing aids in the child's ear and take them out, how to change the volume, and how to change the listening program to fit the environment. Some hearing aids will automatically change the program in an environment. They use this digital signal processing called scene analysis. For example, if you go in a noisy environment, the hearing aid automatically switches and reduces the sensitivity of the microphone a little bit so that you can hear the person closest to you but not hear as much noise further away. We also need to teach parents how to monitor cochlear implants if the child has that device or any other devices the child is using. Number two, we want to remediate communication activity. So help the parents know about auditory learning and constant listening practice. Also help the parents to understand a hierarchy of auditory skill levels that range from discrimination to identification of sounds to true comprehension at the very top. We also want to provide counseling and help them know about psychosocial aspects of hearing loss. So we really need to listen to the needs of the parents and respond appropriately. Help to support the parents through helping to connect them to other families that are going through this. Provide consultation between a counselor and the AR professional when necessary. And think about the needs of the child. So, what kind of support does the child need? When we think about school aged, we've already talked about the development of the IEP. We also need ongoing review and revision of that IEP. I do know how to spell educational. Did anyone catch that? But we want to constantly review the program and the goals and objectives set for that child so that they can be revised when necessary. As mentioned before, we get a new IEP once a year. However, you can definitely revisit goals and objectives anytime throughout the school year. We also want to, of course, manage this child's environment. So we need to make sure that we are providing the best classroom setting as well as any services that the child needs, such as a speech language pathologist, maybe an occupational therapist or physical therapist, particularly when the child has other disabilities. We also want to promote the development of social skills, which is a big aspect of speech language development. And we want to also teach children about hearing conservation and self advocacy. So, hearing conservation programs are important because children with hearing loss need to conserve what hearing they have left, and their peers certainly need to be aware of hearing loss in their environment. That is increasing because of gaming devices, iPods, and iPhones, and the earbuds that kids are sticking in their ears. Self advocacy focuses on helping a child to know when you don't hear, you need to let somebody know. Could you please repeat that? Could you rephrase? Could you write it for me? So, helping the child gain confidence is a big part of working with school age children. Just like infants, we need to focus on audibility and amplification and use of assistive devices in the classroom. So those might include FM systems or digital modulation systems that take the sound from the teacher directly to the child's hearing aids, cochlear implants, or it could be just a simple device with earbuds, but it really helps in noisy and reverberant classrooms. When we think about remediating communication and language, we need to focus on building language skills to promote academic success. So the intervention that we provide really needs to be comprehensive and look at the child's strengths as well as areas of need. So those strengths will really help support the child's functioning in the classroom, but we also need to look at areas of need, and sometimes that's hearing or vocabulary. And so we can ask the teacher to provide a vocabulary list for us to work on with the child prior to a new unit. And so we need to just really identify what this child needs to be successful. We also want to help the child expand on their world knowledge. So, kind of connecting with others and communicating with peers, developing vocabulary and extending current vocabulary to new related vocabulary. Another great area to work on is narrative, so telling stories with self expression, so about things that are occurring in their lives and the lives of their friends, and also need practice with verbal reasoning, which is a really tough skill for kids with hearing loss because of that inability to overhear, in their environment and at home, even at school. Counseling and psychosocial aspects are also critical. So we can provide personal adjustment counseling to adults as well as children. And we want to also make sure that we do not forget those populations with mild hearing loss and auditory processing disorders because they also have difficulties in school given the poor acoustics and the amount of information that they're asked to digest throughout the school day.